which is entering into the inferior vena cava. So because that has stopped, see here, no umbilical vein, no ductus venosus, because the placenta has been removed. So now the inferior vena cava is pure deoxygenated blood which is entering into the right atria. Now no longer any placenta. Second, what happens is, as the amount of blood which is entering from the lungs starts to increase into now the left half of the body. So this is the left atria. It starts to enter into the left atria. So now what happens is the left atria pressure starts to increase and the right atria pressure starts to decrease. As a result, what happens is the foramen ovale, which is the opening here, which was allowing the blood to move from the right side to the left side, this foramen ovale also stops, because now the pressure on the left side of the heart has become high. So what has happened now is the foramen ovale also now closes. I'll tell about foramen ovale little later also. So now the blood from the right atria will start going only into the right ventricle. Now the blood cannot enter into the left atria. Initially, as you can see here, the right atria blood was getting divided into left atria and the right ventricle. But now the right atria blood is only going at one place, that is the right ventricle. From the right ventricle, the blood is then entering into the pulmonary artery, and from the pulmonary artery, this blood is going directly into the lungs for oxygenation. Right? On the other hand, most of the oxygenated blood, I should make it at red, most of the oxygenated blood which is coming from the lungs and is entering into the left side of the heart is entering into the left ventricle, and from here the aortic circulation is starting. So now the aortic circulation is only the blood which is coming from the left atria. This is the aorta. So you have understood what is happening is, now the inferior vena cava blood is entering only into the right atria. From the right atria, it is going only into the right ventricle. From the right ventricle, it is going into the pulmonary artery. From the pulmonary artery, it is going into the lungs, because the pressure in the lungs have fallen. From the lungs, oxygenation is being done. Previously, it was being done by the placenta. Now it is the lungs which are oxygenating. So this oxygenated red blood is entering into the left atria, LA. From the left atria, it is entering into the left ventricle, LV. From the left ventricle, it is entering into the aorta. From the aorta, it is going into the upper half of the body, including the brain and the heart. So the brain and heart continue to receive oxygenated blood. This is then entering into the lower half of the body. And from the lower half of the body, this blood, after is getting deoxygenated, is then again entering into the inferior vena cava. So the whole circulation is again repeating. So now there is no placenta involved in it. So I hope you have all understood how is this thing working. This is the place where the foramen ovale is located. Foramen ovale is located. This is the place where a foramen ovale is located. The foramen ovale is present in the atrial septum and allows the movement of blood from the right atria to the left atria. You are seeing this portion that I am marking, this portion, the circle. This portion is the foramen ovale. So the blood in the fetus from the right side of the heart can enter into the left side of the heart through the foramen ovale. But that is possible because in the fetus, the right-sided pressure is more, left-sided pressure is less. After birth, as I've already showed you, after birth, now it is the left-sided pressure which has become more. Just see this, left-sided pressure has become more. So now the blood cannot enter from the right side to the left side. So all of this blood has only one place to go. And which is the place? All of this right atria blood only goes into the right ventricle. So you can make this diagram. Okay, so now in a full-fledged heart of a newborn, that is after birth, just let me show you what is happening now in a newborn's heart. So this is now after birth. So what is happening in a newborn's heart? So there are four chambers. There is a right atria, there is a left atria, there is a right ventricle, and there is a left ventricle. Right atria, right ventricle, left ventricle. The valve which is located between the right atria and the right ventricle is known as the tricuspid valve. The valve which is located between the left atria and left ventricle is known as the bicuspid valve or the mitral valve. So this is the right atria, this is the left atria, this is the right ventricle, this is the left ventricle. This is the tricuspid valve because it has three cusps, tricuspid valve. And this is the bicuspid valve because it has two cusps or two leaflets, also known as the mitral valve. Right? From the right ventricle arises the pulmonary artery. So this is the pulmonary artery. So from here, the pulmonary artery arises, and this pulmonary artery ideally should go to the lungs. So this goes to the lungs. So the blood is entering into the this is the blood which is going from the right ventricle. It is going up into the lungs for oxygenation. Once it enters into the lungs through the pulmonary artery. So this is the pulmonary artery. So which artery is this? This is the pulmonary artery. So pulmonary artery, although is an artery, it carries deoxygenated blood. Now from the then coming oxygenated blood, as you can see, is coming into the pulmonary veins. So how many pulmonary arteries are there? So you can see the pulmonary artery, the blood is going up into the lungs, and there are total of 4 pulmonary veins, 2 coming from the right lung and 2 are coming from the left lung. These are opening up into the left atria. It is oxygenated blood, so all of this oxygenated blood is entering into the left atria. From the left atria, this blood is then going down into the left ventricle, and from the left ventricle, then the blood enters into the aorta. Then this blood is entering into the aorta. Right? The valve which guards the pulmonary artery is known as the pulmonary valve. The valve which guards the aorta is known as the aortic valve. So let me repeat again, 4 chambers of the heart. One is the right atria, one is the left atria, the right ventricle and the left ventricle. The portion between the right atria and the right ventricle, this valve is known as the tricuspid valve, while the portion between the left atria and the left ventricle, this valve is known as the bicuspid valve or the mitral valve. The valve which guards the pulmonary arteries is known as the pulmonary valve, and the valve which guards the aorta is known as the aortic valve. Blood from the lower half of the body and the upper half of the body enters into the right atria. So this is all deoxygenated blood. So it is all deoxygenated blood. This deoxygenated blood then enters into the right ventricle, and from the right ventricle then it enters into the pulmonary artery. So you can see this blood is going into the pulmonary artery and it is going up into the lungs for oxygenation. After the blood has been oxygenated, the blood enters into the pulmonary vein. So 2 pulmonary veins from the right lung and 2 pulmonary veins from the left lung. So there are a total of 4 pulmonary veins. They enter into the left atria. This blood from the left atria, so this is the left atria, this is now oxygenated blood. This blood from the left atria then enters into the left ventricle, and from the left ventricle then it enters into the aorta. And from the aorta then it is sent into different halves of the body. So this is basically the neonatal circulation. This is the circulation that we normally have after the child is born. Before this, I have told you the fetal circulation and how the fetal circulation changes to the neonatal circulation, that I have also told you. Now, these are a few structures that you should know when they actually close, when they and what they go on to become. The foramen ovale is basically a structure that I told you is the structure between the right atria and the left atria. So it is a structure which allows the blood to move from the right atria to the left atria. Suppose this is the right atria and this is the left atria. This is where the foramen, the cross is where the foramen ovale is present. So the foramen ovale allows the blood to move from the right atria to the left atria. So when does the foramen ovale closes functionally? That means it is present structurally, but when does it closes functionally? Immediately. When does anatomical closure of the foramen ovale occurs? This is an FMG question. When does anatomical closure of the foramen ovale occurs? It is 3 months. And what does foramen ovale goes on to become? Foramen ovale goes on to become the fossa ovalis. Ductus arteriosus, I told you, is what is the connection between the pulmonary artery and the aorta in the fetal life. Ductus arteriosus normally functionally closes between 10 to 15 hours. Ductus arteriosus anatomically closes between 10 to 21 days. Now this is again an FMG question. What is the time when ductus arteriosus physically closes? So ductus arteriosus physically closes between 10 to 21 days, and ductus arteriosus goes on to become the ligamentum arteriosum. Ductus venosus, I told you, was the connection between the umbilical vein and the inferior vena cava in the fetal circulation. Ductus venosus closes immediately. anatomical closure takes 3 to 7 days, and ductus venosus goes on to become the ligamentum venosum. Umbilical artery normally closes immediately, both anatomically and functionally, and goes on to become the medial umbilical ligament. And umbilical vein again goes on to closes immediately and goes on to become the ligamentum teres. So I'll repeat again: functional closure of the foramen ovale immediately, anatomical closure at 3 months, and foramen ovale goes on to become the fossa ovalis. So what does it become after birth? It goes on to become the fossa ovalis. Ductus arteriosus functionally closes at 10 to 15 hours, anatomically closes at 10 to 21 days, and ductus arteriosus goes on to become the ligamentum arteriosum. The ductus venosus closes immediately, functionally, anatomically closes at 3 to 7 days, and the ductus venosus goes on to become the ligamentum venosum. That is, after birth, it becomes the ligamentum venosum. The umbilical artery, it closes immediately, both functional and anatomical closure, as soon as the placenta is removed, and it goes on to become the medial umbilical ligament. The umbilical vein again closes immediately, both functionally and anatomically, and goes on to become the ligamentum teres. So you may write this down. I hope you all have written this. So all of these are fetal structures which are relevant to the heart, and what do they go on to become after the birth of the child? So foramen ovale goes on to become fossa ovalis. Ductus arteriosus goes on to become ligamentum arteriosum. Ductus venosus goes on to become ligamentum venosum. Umbilical artery goes on to become the medial umbilical ligament, and the umbilical vein goes on to become the ligamentum teres. Okay, then another thing that I would like to tell you is NADA's criteria for heart diseases in children. So NADA's criteria for heart diseases in children are certain major or minor criteria which can indicate to the possibility of a heart disease in a child. There are 4 major criteria and there are 5 minor criteria. Presence of 1 major criteria or presence of 2 minor criteria can indicate the presence of heart disease in a child. These criteria are known as the NADA's criteria. Presence of 1 major criteria or 2 minor criteria can indicate to the presence of heart diseases in a child. Which are the major criteria? Major criteria are a systolic heart murmur more than grade 3. So before I come to this, you should know that there are 2 heart sounds. The first heart sound, which is also known as S1, this is the first heart sound. And the second heart sound, which is S2. So all murmurs which occur between the first and the second heart sound are known as systolic murmurs. And all murmurs which occur again between S2 and then S1. So it is S1, S2, S2, S1. So it's like this: first heart sound, second heart sound, first heart sound, second heart sound. So all murmurs which occur between first and the second heart sound. All murmurs which occur between the first heart sound and the second heart sound will be called as systolic murmurs. And all murmurs which occur between the second heart sound and the first heart sound will be called as diastolic murmurs. Each of these murmurs are further graded into 6 categories, that is from a category grading from grade 1 to grade 6, and similarly here also from grade 1 to grade 6. So any systolic murmur which is more than equal to grade 3, any diastolic murmur, now it is not required what is the grade of a diastolic murmur, it may be any grade. Presence of cyanosis, presence of heart failure. So a systolic murmur which should be more than equal to grade 3. So either grade 3, grade 4, grade 5, grade 6. Diastolic murmur of any grade, cyanosis or heart failure. Even if one of these major criteria present, even one, then it can indicate to the presence of a heart disease in a child. The minor criteria are basically 5. Systolic heart murmur which is less than grade 3. Then abnormal second heart sound. There is abnormality in the second heart sound. Abnormal ECG, abnormal X-ray, abnormal blood pressure. So at least 2 out of these 5 criteria or 1 out of the major criteria. So any one of the major criteria, or any 2 of the 5 minor criteria can indicate to the presence of a heart disease in a child. These criteria are known as the NADA's criteria for heart diseases. So what are they called? They are called as NADA's criteria for heart diseases. So I'll again repeat, NADA's criteria for heart diseases in children are major criteria and minor criteria. Major criteria are 4 and minor criteria are 5. Among the major criteria, the 4 major criteria are systolic heart murmur more than equal to grade 3. So it can be grade 3 murmur, grade 4 murmur, grade 5 murmur, or a grade 6 murmur. Any of these 4 types of murmurs, grade 3, grade 4, grade 5, grade 6, systolic murmurs. Diastolic murmur, any grade. Presence of cyanosis, presence of heart failure. You just require the child to have one of these major criteria and it can suggest the possibility of a heart disease. For minor criteria, there are 5 criteria. Systolic heart murmur, which is a soft systolic heart murmur, which means grade 1 or grade 2. Abnormal second heart sound, abnormal ECG, abnormal X-ray, or abnormal blood pressure. I am again repeating, any of the 2 among the minor criteria, any of the 1 among the major criteria can indicate to the possibility of a heart disease in a child. These criteria are known as the NADA's criteria for heart diseases. So using these criteria, it may be possible to identify a group of children who may be suspected of having a heart disease. Obviously, whether this child has a heart disease or not, can be known only once the echocardiogram is done. But at least suspicion of a heart disease can be raised if the child has one of these major criteria or 2 of these minor criteria. Right? I hope you have all written this. Now we come to congenital heart defects in children. Now congenital heart defects, I'll make it here. Congenital heart defects, how are they classified? Now congenital heart defects in children are classified first into 2 main categories. acyanotic heart diseases, that is those heart diseases which do not present with cyanosis, and cyanotic heart diseases, that is heart diseases which presents with cyanosis. So how do you divide congenital heart diseases? Those heart diseases which do not present as cyanosis, they are known as acyanotic heart diseases, and those heart diseases which present with cyanosis, which are known as cyanotic heart diseases. Acyanotic heart diseases then again are divided into diseases which present with a volume overload over the heart. And the second are those heart diseases which present with pressure overload over the heart. So heart diseases which present with volume overload and heart diseases which present with pressure overload. Most of the heart diseases present with volume overload are heart diseases which present with left to right shunts. So they are primarily disorders which present with left to right shunts, while pressure overload lesions are lesions which are associated with ventricular obstructions. But one thing that is common in both of these heart diseases, volume overload and pressure overload, they are acyanotic. They do not present with cyanosis. So I'll again repeat, congenital heart defects are divided into two categories, acyanotic and cyanotic heart diseases. Acyanotic heart diseases again are divided into volume overload and pressure overload diseases. Volume overload diseases primarily are those which present with left to right shunts, that is shunting occurring from the left side of the heart to the right side of the heart. On the other hand, pressure overload lesions are those which create pressure overload on the heart due to ventricle obstruction. So either obstruction in the right ventricle or obstruction in the left ventricle. Let us see the heart diseases which fit under these categories. So volume overload lesions, which are the heart diseases which fit under this category? So the first heart disease which fits under this category is atrial septal defect. Atrial septal defect. In short, it is also called as ASD, atrial septal defect. Here there is movement of blood from the left atria to the right atria through the presence of a defect on the atrial septum. So again, it's a shunt from the left side to the right side because of the presence of a defect in the atrial septum. The second defect which comes in this category is a ventricular septal defect. Ventricular septal defect. In short, it is also called as VSD. It is overall the most common congenital heart disease in children. Overall, the most common congenital heart disease in children is a ventricular septal defect. This is a defect in which there is movement of blood from the left ventricle into the right ventricle. Movement of blood from the left ventricle into the right ventricle because of a defect which is present in the ventricular septum. In the case of atrial septal defect, there was movement of blood from the left atria to the right atria to the presence of an atrial septal defect. In ventricular septal defect, there is movement of blood from the left ventricle into the right ventricle because of the presence of a ventricular septal defect. The third defect which comes under volume overload lesions is a patent ductus arteriosus. In short, it is also called as PDA. If you remember, I told you PDA is a attachment. Ductus arteriosus is an attachment which is connecting the pulmonary artery from the aorta. Remember, pulmonary artery from the aorta. If you remember, this is how I told you. From the pulmonary artery, the blood is going up into the lungs, and this is the aorta. This is what is known as a ductus arteriosus, from the pulmonary artery attaching to the aorta. from the pulmonary artery attaching to the aorta. So this is the ductus arteriosus. In short, we call it as DA. Now, because after birth, the pressure is more in the aorta side rather than the pulmonary artery side, blood always moves from left side to the right side if this ductus arteriosus does not close after birth. Remember, I told you ductus arteriosus should close, functional closure, anatomical closure, and what does it go on to become? I told you ductus arteriosus functionally closes at 10 to 15 hours, and anatomically it should close at 10 to 21 days. But if ductus arteriosus continues to remain patent, it will cause the blood to move like this, from the aorta side to the pulmonary artery side. This is the pulmonary artery side. And that is why, because it is a left to right shunt, it will result in the blood entering into the lungs in large amounts. So this is a type of a left to right shunt. So PDA, the fourth which comes under this category, atrial septal defect first, ventricular septal defect second, patent ductus arteriosus third, and the fourth which comes under this category is known as an endocardial cushion defect. Endocardial cushion defect. It is also known as atrioventricular septal defect. Atrioventricular septal. It is also known as atrioventricular septal defect. I'll just tell you a few things about this disorder. Please just pay attention. I'll just tell you a few things about this disorder. See, endocardial cushion, word endocardial cushion is arrived from cushion-like structures. Just pay attention here. Cushion-like structures which are formed between the atria and the ventricles, and these later on give rise to the lower part of the atrial septum, upper part of the ventricular septum. So just don't focus on the lines that are dotted. Just focus on these lines which are pointing to the arrows. So what you can see is these four things are being formed by the endocardial cushion. So endocardial cushions during embryology time, endocardial cushions are taking part in the formation of first the atrioventricular septum. Atrioventricular septum. You understand, there is one septum between the two atria, there is one septum between the two ventricles, and there is one septa between the atria and the ventricles. This is the one that I am showing, the septa between the atria and the ventricles. This atrioventricular septum is formed by the endocardial cushions. Then endocardial cushions also take part in the formation of the lower part of the atrial septum, which is also known as the septum primum. It is also known as the septum primum. And it is also known to take part in the upper part of the atrial septum. Upper part of the atrial septum. So you understand what is endocardial cushions forming? Endocardial cushions are forming three things during embryology, cardiac embryology. They are forming the septum between the atria and the ventricles. They are forming the lower part of the atrial septum, the thickened portion that I am making. You are seeing the atrial septum, and they are forming the upper part of the ventricular septum. So don't focus on the dotted portion. I'll remove the dotted portion. So now the portion that I am making, which is darkened in color, this is the portion that is formed by the endocardial cushion. So they take part in the formation of the atrioventricular septum, lower part of the atrial septum, and the upper part of the ventricular septum. So whenever there is a defect in the formation of the endocardial cushions, there will be three types of defects. First type of defect is a defect between the atria and the ventricle. So atrioventricular defect. So as a result, there will be only a single atrioventricular valve. Normally, I just now told you there are two valves. One is the valve which is between the right atria and the right ventricle. What is the name of that valve? Between the right atria and right ventricle, it is the tricuspid valve. What is the valve between the left atria and the left ventricle? Bicuspid valve, mitral valve. But in these cases, the complete septum and the valve which are being formed by the endocardial cushion, they are not properly developed. As a result of which, there may be only a single atrioventricular valve. There are no separate mitral valves and tricuspid valves, only a single atrioventricular valve. You can see here, this is the single atrioventricular valve. You can't see the normal separate chambers of the heart, single atrioventricular valves. Normally it should have been like this. But here it is only a single atrioventricular valve. This type of atrioventricular defect or endocardial cushion defect is known as complete defect. There is another type which is known as partial defect. Partial defect, what happens is the valves may be separate. There are two separate valves, but just see the lower part of the atrial septum where the arrow is. The lower part of the atrial septum is not properly developed. That means the septum primum. The lower part of the atrial septum is also known as the septum primum. So septum primum defect is there. It is not properly developed, and even the valves, they may be separate valves. They may be separate tricuspid valve or a separate mitral valve. But even the valves, the leaflets are having some clefts. That means there are abnormal leaflets. Leaflets are not normal. So there are two types of endocardial cushion defects or two types of atrioventricular septal defects. What is the first type of atrioventricular septal defect? A complete atrioventricular septal defect. Here there are no separate tricuspid and bicuspid valves. So the blood will move from the left side of the heart to the right side. So it will, from the left atria, it will enter into the right atria also, and it will enter into the right ventricle also. That is why it is a type of left to right shunt. On the other hand, another type of atrioventricular septal defect is known as partial defect. It is slightly better than the complete defect. In a partial defect, as you can see, at least there are separate tricuspid and bicuspid valves. But even these valves, the leaflets are abnormal, plus the lower part of the atrial septum, which is also known as the septum primum. What is the lower part of the atrial septum called? The lower part of the atrial septum is known as the septum primum. So even the lower part of the atrial septum is not properly developed. So there is a septum primum defect. So septum primum defect is a part of partial or transient atrioventricular septal defect. I hope you have understood. There are two types of endocardial cushion defects. One is complete, one is partial or transient. In a complete defect, as you can see, there is a complete defect. So now what is happening is there is only a single atrioventricular valve and no separate atrioventricular valve as you will normally see. So only a single valve is present. On the other hand, in the case of a partial or transient atrioventricular septal defect, here you can see the valves may be separate. There is a separate tricuspid valve and a separate bicuspid or mitral valve, but the clefts of these valves are having some problems. So the leaflets are having some clefts. That means they are having some abnormalities. When I say clefts, that means they are not normally developed. There are some defects which are present here. So in a partial defect, what is happening is, see here, this is the mitral valve, this is the tricuspid valve. and this is the mitral valve. But even these valves, leaflets are abnormal. They are not properly developed. Plus, there is presence of a septum primum abnormality. What is septum primum abnormality? It is an abnormality which is present in the lower part of the atrial septum. So, septum primum abnormality. Please remember, endocardial cushion defects are very commonly associated with which syndrome? They are very commonly associated with Down syndrome. So they are associated with this syndrome. They are associated with the Down syndrome. Down syndrome is a syndrome which is associated with many abnormalities. One of the abnormalities in Down syndrome is a simian crease. What is a simian crease? Simian crease, now you can see here, normally we have two transverse arches which are running across the palm. In a simian crease, you have actually a single crease which is running transversely across the palm. So unlike these two, there will be only a single crease which is running. There is only a single crease which is running. It is commonly seen in monkeys. That is why the name is a simian's crease. So I remember yesterday when I was seeing the FMG questions, there was a picture of a child's hand in which there was a single crease which was seen running across the palm. They asked which congenital heart defect is commonly associated with this child. So if there is a single simian crease present, it is also known as a simian crease. Single simian crease present, you should think of a you should think of a Down syndrome. And which congenital heart defect is most commonly associated with Down syndrome? Answer, endocardial cushion defects. So which are the heart defects which come under? So let me revise once again. Congenital heart defects may be acyanotic, they may be cyanotic. Acyanotic congenital heart defects further are divided up into volume overload and pressure overload. Volume overload heart defects primarily are heart defects which present with left to right shunts, while pressure overload heart defects are the heart defects which primarily are associated with ventricular obstructions. The volume overload defects include atrial septal defects, includes ventricular septal defects, include a patent ductus arteriosus, and include endocardial cushion defect, which is very commonly associated with Down syndrome. So these are the four defects which come under volume overload lesions. Another question that I found yesterday was, ventricular septal defect is which type of a congenital heart defect? Choice A was volume overload, choice B was pressure overload, choice C was both volume and pressure overload, and choice D was a cyanotic heart defect. Ventricular septal defect is a pure volume overload lesion. Atrial septal defects, volume overload defect. Ventricular septal defect, volume overload defect. Patent ductus arteriosus, volume overload defect. Endocardial cushion defect, volume overload defect. And which is the most common congenital heart defect associated with Down syndrome? It is endocardial cushion defect. A simian crease is a single transverse crease running across the palm, which is commonly seen in Down syndrome. And when it comes to Down syndrome, the heart defect that should immediately come to your mind is a endocardial cushion defect. Then we come to pressure overload lesions. Which are the heart defects which come under pressure overload lesions? The heart defects which come under pressure overload lesions now pressure overload lesions are the lesions associated with ventricular obstructions. So when there is a left ventricle obstruction, it will lead to aortic stenosis. So stenosis at the level of aortic valve, aortic stenosis. When there is obstruction on the right side of the heart, that is at the level of pulmonary valve, it is called as pulmonary stenosis. And when there is a obstruction occurring in the arch of aorta, then this condition is known as coarctation of aorta. So which are the pressure overload lesions? The pressure overload lesions are aortic stenosis, pulmonary stenosis, and coarctation of aorta. Which are the volume overload lesions? Atrial septal defects, ventricular septal defects, patent ductus arteriosus, and endocardial cushion defects. So these are the 7 acyanotic congenital heart defects which are important for your exams. So which are the acyanotic congenital heart defects that you should know of? 4 of them are volume overload, 3 of them are pressure overload. Which are the 4 which are volume overload? Atrial septal defects, ventricular septal defects, patent ductus arteriosus, and endocardial cushion defects, also known as atrioventricular septal defects. Which are the 3 defects which are associated with pressure overload? Aortic stenosis, pulmonary stenosis, and coarctation of aorta. Coarctation of aorta is a constriction which is present in the arch of the aorta. You may write this down, then I will come to cyanotic heart diseases. I hope you have written this. Now let us come to cyanotic heart defects. Let us now come to cyanotic heart defects. So, congenital heart defects, I told you are acyanotic, and I told you are cyanotic. Acyanotic, again I told you are volume overload and pressure overload. Now let us come to cyanotic heart disease. Cyanotic heart diseases are divided up into 2 categories. Those which are associated with reduced pulmonary blood flow, second, those which are associated with increased pulmonary blood flow. So those associated with decreased pulmonary blood flow, and those cyanotic heart diseases with increased pulmonary blood flow. Now cyanotic heart diseases associated with decreased pulmonary blood flow further are divided up into 2 categories. Those which are associated with right ventricle hypertrophy. Those associated with right ventricle hypertrophy. In short, we call it as those associated with RVH, and those which are associated with left ventricle hypertrophy. In short, LVH. So cyanotic heart diseases are divided up into 2 categories. those which are associated with decrease in the pulmonary blood flow, and those which are associated with increase in the pulmonary blood flow. Those which are associated with decrease in the pulmonary blood flow can further be divided up into two categories. Cyanotic heart disease with decreased pulmonary blood flow with a right ventricle hypertrophy, and cyanotic heart disease with a decreased pulmonary blood flow with a left ventricle hypertrophy. So which is the heart disease which falls in the first category? Cyanotic heart disease with decrease in the pulmonary blood flow with the right ventricle hypertrophy. The best congenital heart disease is tetralogy of Fallot. On the other hand, cyanotic heart disease associated with decreased pulmonary blood flow with left ventricle hypertrophy, the best example is a tricuspid atresia. Tetralogy of Fallot and tricuspid atresia. Why is tetralogy of Fallot known as tetralogy? Because there are four important components of tetralogy of Fallot. Which are the four components of tetralogy of Fallot? The first component is a ventricular septal defect. The second component is a large aorta which overrides, which starts from just above the ventricular septal defect. The third component is a pulmonary stenosis, which usually is subvalvular pulmonary stenosis. What is meant by subvalvular pulmonary stenosis? The obstruction is there at the level of the pulmonary artery, but it is at just below the level of the pulmonary valve. See, the stenosis can be either valvular, which is at the level of the valve. It can be supravalvular, above the level of valve. It can be subvalvular, which is below the level of valve. Now, both valvular and subvalvular pulmonary stenosis can occur in TOF, but subvalvular pulmonary stenosis is much more common. So, subvalvular pulmonary stenosis is much more common in comparison to valvular pulmonary stenosis in tetralogy of Fallot. Why do we say tetralogy of Fallot? Because there are four components. First is a ventricular septal defect. Second is an aortic stenosis. Second is an aorta which overrides the ventricular septal defect. Third is a pulmonary stenosis. And fourth is a right ventricle hypertrophy. That is why we are putting it under decreased pulmonary blood flow with right ventricle hypertrophy, because one of the components of TOF is a right ventricle hypertrophy. So what are the components of tetralogy of Fallot? Why do we call it as tetralogy? The components of tetralogy of Fallot are, please see this. The components of tetralogy of Fallot are like this. So there is a ventricular septal defect. You can see a ventricular septal defect in the circle. There is a ventricle defect in the ventricular septum. There is a large aorta which overrides. When I say it overrides, that means the aorta is rising from just above the ventricular septum. This is the aorta. Plus, this is the pulmonary artery. This is the pulmonary artery. Plus, there is stenosis at the subvalvular level. So, subvalvular pulmonary stenosis. Plus, there is a right ventricle hypertrophy. This is the right ventricle. So, this is hypertrophic. So, plus there is a right ventricle hypertrophy. So, that is why we call it as tetralogy of Fallot. First component, pulmonary stenosis. Second component, right ventricle hypertrophy. Third component, a large VSD. And fourth component, an aorta which overrides the VSD. Please remember, if you add ASD to these four components, if you add ASD, then it becomes what is known as the pentad of Fallot. What is pentad of Fallot? What is pentad of Fallot? It is the four components of the tetralogy of Fallot plus ASD. I hope there is no confusion. Tetralogy of Fallot is these four components: VSD, aorta overriding the VSD, pulmonary stenosis, and a right ventricle hypertrophy. When you add ASD to this, it becomes the pentad of Fallot. Right? Now you can understand this thing. Please pay attention here just for a moment. You can understand this thing that when there is a pulmonary stenosis in TOF, the circled portion. When there is a pulmonary stenosis in top, what will happen is the blood from the right ventricle during certain times will not be able to enter into the pulmonary artery. So this blood through the ventricular septal defect will shunt into the left ventricle. So in the left ventricle, there will be a mixing of left ventricle and right ventricle blood. That means a mixing of oxygenated and deoxygenated blood. This is why this disease becomes a cyanotic heart disease. This is why it becomes a cyanotic heart disease. It is in fact the most common cyanotic heart disease which occurs after 1 year of age. The children do not present with cyanosis immediately at birth. So it's the most common cyanotic heart disease, cyanotic congenital heart disease after infancy. In infancy, during the time of infancy, majority of these children present with what is known as the TET spells. What is a TET spell? A TET spell is a spell of cyanosis because of the blood moving from the right ventricle into the left ventricle. So mixing of blood. Otherwise, when the right ventricle contracts, some of this blood can enter into the pulmonary artery. But what happens is during certain times, such as during the time when the child cries, during the time when the child is straining during defecation. So at certain times when the child is irritable, at certain times the pulmonary artery valve will close suddenly. Subvalvular pulmonary stenosis will close suddenly, and this will allow the blood. Now the blood from the right ventricle cannot enter into the pulmonary artery. So this will allow the blood to enter into the left ventricle, resulting in mixing of the left ventricle and right ventricle blood. These spells of cyanosis then are known as the TET spells or are known as the hypercyanotic spells. What are they called? Hypercyanotic spells. How do you manage these TET spells? Management. So how do you manage these TET spells? So see, what is the cause of the TET spells? As you can see here, the cause of the TET spells is there is a shunting from, please pay attention here, there is shunting from the left side of the heart to the right side of the heart. There's shunting from the right side of the heart to the left side of the, please pay attention here. What is the cause of TET spells? The cause of TET spells is that the pulmonary artery, which is arising from the right ventricle, because it has suddenly closed, there is shunting of blood from the right side of the heart to the left side of the heart through the ventricular septal defect. You can see in the picture, the blue arrow. So there is a shunting of blood from the right side of the heart to the left side of the heart. So according to me, there are two ways of treating a TET spell. Because a TET spell will stop if this shunting from the right side of the heart will stop going to the left side, either increase the pressure of the left side or decrease the pressure of the right side. Isn't it? The blood is moving from the right side to the left side. So there are two ways of stopping it. What are the two ways of stopping it? Either increase the pressure on the left side or you decrease the pressure on the right side. In both cases, the movement of blood from the right side to left side will decrease. Either